Bismillahirrahmanirrahim. Good afternoon. Welcome you all to our weekly session of Oncology Club that we have been doing for the last 1.5 years almost. So you know that we have finished our lecture series. Now we are trying to discuss some real life case discussion and everyday problems. Today we will be talking on role of radiotherapy in breast cancer, but unfortunately in one session we cannot cover all. So today we will be mostly focusing on whole breast radiotherapy. So today we have two local faculties. First, let me introduce Dr. Faria Sharmin, who is the Associate Consultant of Square Hospital, a very brilliant radiation oncologist of our country, and Dr. Masudul Hassan Orup, who is the Assistant Professor of Department of Radiation Oncology in NICRH. I feel sad when I see that he is not my colleague, such a wonderful oncologist. And we have three panel of experts today. Our old friend, Dr. John Conybeare, who is the consultant oncologist in BART NHS Trust, UK. I'm sure he is cycling and any moment he will join us. And we have Dr. Irfan Ahmed, who is a consultant in the Department of Radiation Oncology, Rajiv Gandhi Cancer Institute, India. Irfan is somebody new with us, but Rajiv Gandhi is an old friend of us. So this is a new representative of our old friend. And finally, Dr. S.K. Farid Ahmed, who is an oncoplastic surgeon, Wickham Hospital, in UK and also works in Bangladesh, a doctor born from Bangladesh working in UK. So we are happy to have all these five faculties with us. Our program, we want to start with few words from our president and our patron, Dr. Amy Hai. Sir, please.
Thank you, Paul. Bismillahirrahmanirrahim. As usual, we are starting our weekly webinars. This topic is role of radiotherapy in breast cancer. Possibly we'll be discussing only the whole breast radiation. Without any delay, I think we should start my heartfelt thanks to all the participants, particularly consultants from abroad, Conybeare, Dr. Irfan, for new to us, and also Dr. Farid. And Masum. Without any delay, let's start. Thank you very much.
Thank you, sir. Thank you, sir. Just a quick recap that it is a 60 minutes program. We will be approaching few situations to our local faculties, and then we will discuss. We take an opinion poll from all the participants, and any participants, even after want to put some question, can put in the chat box, and the best performer of the poll will be awarded as the best three performer the next session. And finally, we will discuss some evidences and we will get an opinion from our faculties. So I'm going to start our case. It's a 30 years young lady, premenopausal, presented with a lump in the right breast. Ultrasonogram showed that it's a periolar areolar lesion of 4 centimeter size with multiple X-ray lymph nodes. Unfortunately, her mother is a breast cancer survivor for 10 years. So she has a positive family history. And the core biopsy was done from the mass and FNAC from the node was also done. IDC grade 3, FNAC positive, ER/PR HER2 negative. It's a triple negative case. Ki67 is 30%. And as her family history was positive, BRCA was done and BRCA came out to be positive. No more imaging showed any metastatic sign. So patient was treated with neoadjuvant chemotherapy, AC followed by paclitaxel and carboplatin 4+4, and there was a good clinical response. So now this is the scenario. We want to post our first question. Mahfuz, please show the question. Mahfuz. So 30 years age, family history positive, perioral lesion of right breast, T2N1, core biopsy, IDC grade 3, TNBC, Ki67, 30, BRCA positive, FNAC node positive, NSCT, AC, paclitaxel, carboplatin. Radiologically, there was 1 centimeter and still node is there. Now, what is your preference? Mastectomy followed by PMRT, mastectomy followed by PMRT and RNI, BCS followed by whole breast radiotherapy, or BCS followed by whole breast radiotherapy and RNI. So we have 28 participants, till now only 5 of them participated. I will request everybody to participate except the co-host because we cannot join the poll. So please, quick, we don't have much time. Only 39% has 42%. Good. 16. So Mahfuz, I think we can stop now. Okay. So 1 out of 19 participants favored mastectomy followed by PMRT. 7 out of 19 favored mastectomy followed by PMRT with RNI. 1 out of 19 suggested breast conservation followed by whole breast radiotherapy. And 10 out of 19, majority 53% was in favor of breast conservation followed by whole breast radiotherapy and RNI. So I move to our faculties, local faculties. I start with Faria, that what will be your take? Because she was a young lady, family history positive, perioral lesion, we know central lesion are having worse prognosis, and it was a locally advanced disease, we can say, and triple negative, BRCA positive, and after neoadjuvant chemotherapy, still there are some tumor and node positive. What you will do, Faria? Faria, can you hear me?
Yes, Priya. Am
Yes.
I audible?
Yes, you are audible.
Okay. I will go for BPA followed by WBRT and RNI with boost.
So you want to go to the last option. You are in favor of going for, you will be going for breast conservation with nodal dissection or assembly, whatever is. Not, so of course, dissection. And
Nodal
then you want to go for whole breast radiotherapy and
nodal dissection is followed by whole breast.
So I have a supplementary question, that don't you think that so many risk factors like young age, family history, triple negative could be a barrier of a decision of going for this whole breast radiotherapy, breast conservation? Arup, Masudul Hassan Arup. So what is your comment? Faria is in favor of going for breast conservation in such a high risky lady. She's young, only 30 years. Family history is positive, triple negative. Will you be taking the same decision, or you want to go for something more aggressive to save the life?
Sir, thank you, sir. Actually, seeing all the parameters of the patient who has got family history, positive family history, and we have said that BRCA1 or 2 mutation positive. I am always in favor of over treatment, because sometimes if the disease recurs, then the recurrent disease, it is always tough to fight with. So I would like to go for mastectomy and axillary clearance followed by radiotherapy in the chest wall and also the RNI.
Okay, Arup. So you are scared, you are concerned, I will rather say, because of the so many risk factors that we brought. Any possible risk factor is there. So you are in favor of going for mastectomy. Why not? Yes, that could be an option, but you are scared that if the recurrence is happening, so you want to prevent the recurrence, because probably you are telling that in mastectomy recurrence is less than whole breast. But do you think that it is going to? So we will come to that later on. We will be discussing a mastectomy versus.
Actually, mastectomy and breast preserving surgery followed by whole breast radiotherapy, they have got equivalent result. But in these cases, that a very young patient and family history is positive, and just only for these few points, I'm in favor of mastectomy. But always there will be a choice of the patient. If the patient wants to preserve her breast, then we can go for it. And if patient wants, sometimes we say that patient can go for breast conservation. We motivate the patient for breast conservation, but a patient wants that, no, don't need it. I need my life. So in
Okay,
those
Arup,
cases,
that is a
sometimes
different thing.
yes.
I got your point. So we are trying to make it a bit quick. So there is a comment in the chat box. Thanks, Shahida. T2N1 is not locally advanced. That was my mistake. I wanted to bring that factor also. It should be, I should have made it a more advanced. Okay, let us consider it as a locally advanced. So Farid, I know you are driving now. Are you in a position to talk? Farid? Because I don't see John has joined. Or we can, okay, Farid, can you talk now?
I can talk. Yeah,
Okay.
I can talk.
So as a surgeon,
What I'm trying to say is, first of all, thank you very much. Interesting topic. One thing I want to make a question. What makes you think that a mastectomy will guarantee saving life? Because
No.
that might confuse us.
I understand. Farid, we will come to that point.
Okay.
Survival, we will
Okay.
come. We are talking that as a
Okay, number
surgeon,
two.
yes.
This patient, you have given all the valid options, but there are fewer options gone missing. Like because of her age, BRCA mutation positive, and all other risk factors like TNBC and other things, young age. One may wish to also consider discussing mastectomy and a delayed reconstruction on the affected breast and contralateral breast risk reducing surgery. And these are well practiced, done in developed countries. One may ask a question that whether there is a survival benefit of doing risk reducing surgery. Then same applies to mastectomy as well, because the mastectomy is not going to do any additional survival as well. And those who worry about recurrence, it is also important to understand that the first cancer, the index cancer dictates survival, not the subsequent recurrence. The only problem is when there is a recurrence, there is a big hassle of going through again this management plan, which would compromise patients' quality of life. So that is where the problem be, not because of patients' survival will be compromised. So that is important to understand. And again, patient choice is absolutely important as well, the decision making. With the BRCA mutation, it's not only the breast. We may well have to address our ovaries as well at some point later on. And it depends on patients whether family is complete or not. If not, before we starting chemotherapy, we would be thinking about fertility specialist, fertility clinic referral as well. So we need to have all this information to be considered before we make a plan in MDD that what we are going to recommend to this patient for surgical management. Thank you.
Thank you, Farid. You have covered so many things. So I was trying to focus very simple thing. If Dr. Faria is in favor of breast conservation, Irfan, in your center, do you think these factors that intentionally we brought in, like the young age, TNBC, say it is a locally advanced disease, responded good to neoadjuvant chemotherapy, history of neoadjuvant chemotherapy, grade 3, will you consider it as a barrier against breast conservation therapy?
Not at all, sir. Not at all. You know, like you mentioned, the post-surgery, you mentioned the histopathology was about 1 centimeter residual, and I couldn't see how many nodes were involved in the post-op pathology report. But as long as it's N1 and there's no extracapsular extension, yes, like I said, N1. So 1 node, 2 nodes, 3 nodes, without extracapsular extension, with a 1 centimeter residual after neoadjuvant chemotherapy, I don't think breast conservation is a barrier, like Dr. Farid was saying. To take it even one step further, I mean, I would also not be hesitant at all in recommending hyperfractionation to this patient. You know, as we were discussing, there is ample evidence now, and to suggest that hyperfractionation is a valid option for this patient. Initially, there were some concerns whether you should be treating node-positive patients, triple-negative patients, young patients with hyperfractionation or not. I don't think there is any barrier now as far as this question is also concerned.
Thank you.
I
Yeah.
would, however, like to discuss, what nodal levels, should we be treating for this patient? If she is undergoing breast conservation surgery, our practice would be, like you mentioned, it's in the periareolar region. I would probably take the internal mammary chain. I would probably take the undissected axilla, and I would take the supraclavicular fossa and leave the level 1 and 2 untouched if she's undergoing breast conservation. And right.
Okay, Irfan, I want to stop here because we are going to have another session on RNI.
Right.
Today, intentionally, I didn't keep this axilla management because it itself is a huge ocean that we will be swimming in. So today, I was trying to focus especially that let's see what the data says, that there is a paper, it was published in Red Journal in 2006. It's an old paper. And they have shown that there is no significant difference of breast conservation in young women compared to mastectomy. And they have taken the 20 to 49 years age group, and their total number is around 1,597 patients they have taken. So 50 and 800 was, majority was 1,500, around 1,600 was BCT and 800 was MRM. So it was a huge number, and they have shown that young age is not a factor to affect the decision of breast conservation. And this is a paper that was published in Acta Oncologica 2 2016, and they have tried to identify the effect of family history, and they have taken a cohort of 1,100 patients less than 50 years and 1,128 patients receiving breast conservation surgery, and they have shown that positive family history is not an indicator to contradict the decision of breast conservation. And again, the TNBC, this is the paper published in 2013 in Annals of Surgical Oncology. They have taken a series of 1,242 TNBC patients from 1999 to 2008, and they have made a follow-up of 78.3 months, the range of 1 to 156 months, and they have shown that 5 years locoregional recurrence is 4.7% achieved in large group women T1, T2, TNBC treated with multimodality treatment. BCT was equally effective as mastectomy for local and distal control. BRCA, I have picked up two papers. One is 2010, and they have shown that BRCA muted patient can be safely treated by BCT, and its outcome is comparable. And here they have seen the result of 655 women, and they have equally divided in BCT and mastectomy, almost equally. And then this is a paper published in 2019 in Annals of Surgical Oncology, and here they have taken the outcome of, in a Dutch paper, 10 Dutch centers, and 5,820 patients they have looked into it, and there BRCA was BRCA 1 was 191 and BRCA 2 was 70. And when they have concluded that BRCA positivity is not a contraindication, should not be a contraindication for breast conservation. So now come to the Astro consensus guideline. They are telling that decision of hyperfractionated whole-based radiotherapy should be independent of tumor grade, of hormone receptor status, and laterality, and also chemotherapy, neoadjuvant chemotherapy history. And younger or older is not a factor, and it can be also an issue for DCIS. So that was the discussion of first question. I intentionally brought so many things in first question because we think all these things, young age, triple negative, BRCA, I mean, family history, so many things, scary, because we know in long term, there is a higher chance of recurrence. We will be discussing on that, but the overall survival is the issue. So can we go for this? But as long as such a strong recommendation of 100% consensus in Astro guideline, so I think we can safely discuss the possibility of breast conservation in this patient. But yes, what Dr. Farid says, if patient is eager for mastectomy, we should respect the choice of the patient, but we need to convince them in a proper way that there is a possibility of offering her breast conservation with equal outcome. And there is enough recommendation that even these are independently a high risk factor, but this cannot be a barrier for taking a decision of organ preservation in a young lady of 30 years. So I think we should think in a different way, that in a young lady, it is more important to conserve the breast, because it is 70 years, 60 years, maybe we can think in our culture a different way. So this is where our first question was. Now, John has joined. John, I will be involving you in our subsequent question. So next question is that we have been already talking. Please show the second question. Mahfouz. Hi, John. So mastectomy offers better survival than breast conservation. True, false, or it is true in special cases? Because the question of survival, question of recurrence, and there are so many things that we try to address. So we have till now 38% participants voted. We want more participation. So it's a very small question, but I'm still giving up to 1 minute's time. 9. Mahfouz, stop. Okay, so we have 67% participation, 23 out of 34. 3 out of 23 said it is true that mastectomy offers better survival. 7 believe that it is not true. And 13, majority think that in special case, it can offer a survival benefit. So it's really interesting to see the opinion poll. Now I come to Arup. I want yes or no answer. Does mastectomy give better survival than breast conservation? Yes or no?
No, sir. Actually, just mastectomy can offer only, there is no survival advantage of mastectomy.
So answer is yes or no, survival benefit. I ask for survival. I don't want anything more.
No, there is no survival benefit.
By giving mastectomy, we are not offering any survival benefit to a patient. Faria, agreed with Arup?
Sometimes in some special cases, breast conserving therapy is not indicated. Then we can do
the question is, Faria, is there any survival benefit?
No.
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 Blunt, no. There is no if, but. Okay. So, John, coming back to you, is there any situation where we can claim that mastectomy can offer some survival benefit over breast conservation therapy?
Yeah, I think in inflammatory breast cancer. So select cases where breast conservation is not a good idea.
So let me ask you a revised question. Can we do conservation in inflammatory breast cancer? Very good response to NSCT. Can we do conservation?
I've never done it and I've never seen anyone done it. So my answer, I think it's no.
So this is a situation that in inflammatory breast cancer, you are not in favor of doing conservation. Irfan, any experience of?
Unfortunately, we don't have our surgeons are not very adventurous in that regard. When it comes to inflammatory cancer, it's only the medical oncologist call. I've never actually seen someone do breast cancer.
Have you ever done conservation after a wonderful response of neoadjuvant, total radiological response?
No.
May I know why?
I haven't.
Why?
Because of high risk of recurrence, local recurrence. It is not to do with the survival. recurrence would not compromise her survival. As I said before, the index cancer, meaning the first cancer, would have dictated her survival anyway, not the subsequent recurrences. So it is the problem with inflammatory breast cancer. So we would offer actually simple mastectomy. I mean, look, we are not against mastectomy. In many cases of breast cancer, we need mastectomy. But what I would say is not in the name of survival. In fact, it should be other way true. Look at the Swedish trial, 48,000, nearly 50,000 patients. The trial has confirmed that mastectomy group plus radiotherapy, and other group was breast conserving surgery with radiotherapy. Mastectomy group survival was less than breast conserving surgery. So this study, I'm sure you are going to address that at some point later today. This study confirms BCS has got a better survival after adjusting all the risks. And in fact, both groups had radiotherapy. So it's not that the radiotherapy is responsible for breast for better survival. It is just how it is. I think perception is that the mastectomy will confer better survival, but the reality is opposite. Thank you.
So thanks for it. If we look at the data, I mean, the reference series is that initially we were trying to bring up that breast conservation is non-inferior to mastectomy, but as some of our colleagues was trying to point out that the recurrence rate was higher in lumpectomy BCT group compared to mastectomy. But if you go back to our earlier slide, that it was always comparable when it is the survival. But what Farid was trying to say that first I want to bring an old paper. It was a presentation in 2014. This lady, Catherine Parker, she was a research fellow in MD Anderson, but later on she switched over. She made a presentation and showed first that there is a cohort where they found that the BCT was showing better overall survival in both compared to BCS, that is the radiotherapy was these hormone receptor and hormone receptor positive and negative. And there was no difference of overall survival in mastectomy and breast conservation surgery. So she was the first lady to make some noise. And yes, John. Want to say something, John?
Yeah, I did. It's stage 1 disease, though.
Yeah, it was an early stage disease. Yeah, it is not the, true.
I don't know if the trials include inflammatory breast cancer,
No.
mastectomy versus local control situations. So I don't think the evidence is there to say it is as good, you know?
Yeah, thanks, John. These are early stage breast cancer. And the Swedish trial that Farid was trying to say, it is a huge number, but again, just for the note, as you mentioned, these are not advanced disease, but you know, this is giving us a perception that it is not an inferior thing. We are not going to sell the superiority, but probably the concept of non-inferiority can be, knocked down with this because, yeah, John.
My vision is that to be cured of cancer, your cellular burden has to be reduced to 0. Yeah, so cure equates to no cancer cells left, and therefore if your local control is inferior based on an advanced breast cancer, then you'll never affect survival because you'll always have an increased risk of local recurrence. So therefore, you know, it doesn't factor in, I don't think, for locally advanced breast cancer. You know, even if you have a fantastic radiological response, clinical response, we know that under the microscope you can still find residual cells, you know. So I'd say survival, because it hasn't been tested, we don't know, you know. So I would still say local control in early stage, fair enough, you know, mastectomy versus lumpectomy and radiotherapy. But when it comes to advanced disease, we haven't tested the hypothesis, and I don't think anyone ever would.
Irfan, John is trying to focus that all these papers very rightly said these are early stage, not a locally advanced. So the conclusion of these papers were that yes, it is non-inferior, sometimes it is superior in early stage, low risk group. But when it becomes a locally advanced, even we are getting a fantastic response. We are doing breast conservation, but unfortunately till now we don't have any robust data in favor of making the same tone of the early stage. Any comment on that?
I agree with Dr. John. You know, most of our experiences is extrapolation from early stage breast cancers. And till the time we don't have more information, I don't think we'll ever be able in a position to say that this is applicable for all patients. The exception, of course, being inflammatory breast cancer. You know, that is the only domain left for mastectomy, if it is, if for mastectomy only. For every other situation, I believe breast conservation should be offered after neoadjuvant. So again, now it's difficult to somewhat, let's say, remove the effects of systemic treatment from survival when we are talking about neoadjuvant chemotherapy. You know, we are seeing response rates increase. Initially, in the initial 4 or 5 trials, they're about in the tune of about 20%. But today's generations of neoadjuvant chemotherapy, you're reaching up to a pathological complete response. I'm talking about up to about 30 to 35%. And essentially, what you're also doing is you're chemo-selecting them. You know, you're only going to ultimately offer local treatment to those patients who do not progress during their neoadjuvant chemotherapy. So there's some amount of chemo selection happening there. Whether there will ever be a study which will be able to compare after neoadjuvant chemotherapy mastectomy versus breast conservation, I don't know. But this is definitely a favorable cohort, and the differences, again, may not be significant if there are any.
John, interesting discussion. So for early stage, no debate. Go for conservation. Inflammatory breast cancer, no debate, go for mastectomy. But LABC, say we are making 2 groups. One, very good response. One is a partial response. So in a very good response, a complete pathological response or near to complete pathological response, patient is eager to do for breast conservation. Another patient don't know. Patient says that what is best for me, do it. And it is a partial response. What will be your take? Will you go for conservation or you will be going for mastectomy? John.
Yeah, I have to say I've been caught out, you know, where I've had patients who've had, in inverted commas, fantastic responses, you know, a 10 centimeter tumor, which radiologically has had a complete response, and they've been found to have 7 centimeters of residual disease speckled over, you know, so cellular residual disease over that diameter, you know, not a hard mass, but just islands of cells left. And, you know, they wanted a lumpectomy because they had a fantastic response, but they still had disease in their mastectomy specimen. And so I do feel really nervous, Kamal, about relying on radiology. You know, I just don't think it's there yet at a cellular level. So I would, you know, it's a cop-out, but I would judge it on a case-by-case basis. You know, I don't think there's a hard, fast yes or no.
Thanks, John. That is the real-life answer. We should not be biased of doing every case conservation, and we should not be rigid to do every case mastectomy. Here comes the clinical judgment. Here comes the discussion. Here comes the, what experience comes out, because science is not giving yet all the answers. There are some gray zone always, and that will time probably we'll have more data, as Irfan was telling, selection of chemo. Maybe we'll have some genetic markers, some molecular profiling that will tell us that where we can go for escalation, where we go for de-escalation. Say in head and neck, P16 came out, something may come up, and that may give us some more clue. But till now, as John said, that for a early stage, definitely we can promote breast conservation without any hesitancy, because there are enough data. For inflammatory breast cancer like situation, we have no option to yet any data to favor breast conservation. But when it's a locally advanced disease and there is a good response, so-called very good response, because to see the pathological complete response, we need to do a surgery. Before surgery, as John said, sometimes wonderful radiological response end up with so many nodes or so many tumors. So our judgment becomes wrong. So here, I think this is a gray zone. We can discuss in the MDT and discuss the pros and cons. Every single patient we need to discuss and decide, and also keep the patient in the discussion so that she can also take part in the decision making, because what I realized till today, probably this is a gray zone. So my request is to my colleagues that in our perspective, we should not be very rigid that every case we need to do conservation, or there is no role of conservation. Every case we should be doing mastectomy. Today in 2021, I think we should not be there. We should be flexible and we should be looking at the patient. But the message is that till now, mastectomy has not shown higher survival benefit compared to conservation, but the leukocyte recurrence is high. There are many series have shown that. But as John said, every case is different. So now we move to our next question. Mahfuz, next question. So we decided to go for breast conservation. Surgery is done. Now, what will be your preferred fractionation? 40 gray 15 fraction, 42.5 gray 16 fraction, or 50 gray 25 fraction, or do you have any other? So please quick. So everybody of us are doing hyperfractionation. So we should be very quick in answering this. We have given four choices. Ten more seconds I'm going to give, then I'm going to stop. 50 seconds, Mahfuz, stop the poll. Okay, stop the poll, Mahfuz. Okay, so we have 58% participation, 17 out of 29. Majority, 60% almost, were in favor of 40 gray 15 fraction. Then next is 5 out of 17 is 42.5 gray 16 fraction, and for 24% is in favor of 50 gray 25 fraction for whole breast radiotherapy. That is really good. So now, Dr. Faria, what will be your fractionation? Will you pick 40 gray or 42.5 gray or 50 gray? Can you please louder?
Anyone. Yeah, we can take any one, 14.
But what will be your take? What you will do? What you do?
Okay. 14, 15 fraction.
Sorry?
40 is 15 fraction.
40, 15. Arup, I know you have
Yes, sir.
two
Thank you.
options. You are working in a private center and you are also working in the biggest center of our country, National Institute. So do you do
Yes,
same
sir.
practice in both center, or you do two fractionation in two centers?
No, sir. I do the same practice in my both institution, 40-15, 40 gray and 15 fraction. It is we practice it in the National Institute, and also I personally practice it in my private institute.
So everywhere you use 40 by 15. So I see in the chat box what was the nodal status. Assume node was positive. And Shuman asked about 26.5. We will come to that later on. I kept that total question for John. Don't worry, we will have some discussion. I know you are very interested for that. We will be talking on that. So Irfan, what is your fractionation in your center?
So we just preferred purely from a numbers game 42.5 and 16. Just because it's just that little bit radiobiologically closer to 15-25. 14-15, yes, if this patient would have been node negative and she perfectly fits into the into the START trials, 14-15. She's node positive, just a little edge towards 42.5 and 16.
So you are in favor of two types. If it is a, the decent type of disease, not high burden, 40-15, and if there is a nodal burden, you go to 42.5.
Just that little, 2 or 3 gray equivalent more.
John, I know you are. This is the old story for you. Now you are in the era of 5-5. So, but any comment about this Canadian and the British 40-15 and 42.5 by 16?
Yeah, so I'd say our standard has always been 40 and 15. I haven't used, and I don't know anyone who uses in my MBTs 16 fractions. So
one was trying to tell that as 16 fraction, 42.5 is more closer to BED in 50. So is there any superiority you find?
So I'm not aware of any sort of overwhelming data to suggest that 16 is significantly better in terms of relapse disease, in terms of local control rates. So,
okay. So I went to again took the help of Astro Guideline, and they are recommending any of them to do hyperfractionation. That is interesting that Astro is no more recommending 50 grade 25 fraction. Whether it is a node positive or negative, they are telling that with or without Exela, we can select either the Canadian or the British, any protocol that is 40-15 or 42.5. So that was the message that I want to share, that in whole breast radiotherapy, still the main recommendation is to go for hyperfractionation, and the rare recommendation is 40-15 or 42.5 16. But this was a publication 2018. If it was today, maybe they have added something more that we'll be discussing a bit later. So, okay. I have a supplementary question to Arup. This patient is having, it was HER2 positive and taking trastuzumab, and it is a left-sided breast. Will you go hyperfractionation or will you go for conventional fractionation? Because the left-sided breast, we know trastuzumab has some cardiac issues. And are you scared of your hard dose, or you are still courageous to go with hyperfractionation?
Sir, in case of BCS, I would go for hyperfractionation, though it is left-sided and trastuzumab, concurrent trastuzumab, because the modern radiotherapy technique, it can spare the heart very effectively, and we can spare the heart by doing IMRT, forward IMRT, or even 3D CRT. We can save a significant, or LED. So I think I didn't find in any guideline that they have prohibited the left-sided breast cancer getting Herceptin won't get hyperfractionation. So personally, I think that I can go for hyperfractionation, though it is a left-sided malignancy.
Great. Maria, agreed with Arup, or you want to change something? Maria, are you there?
Yeah, I'm agreed with all of you.
Okay, so you are
for hyperfractionation. Yeah.
Okay, great. Irfan, do you have any reservation in your center for left-sided breast with trastuzumab?
None whatsoever, sir.
Great. So we all are in agreement. So I'm not bothering John. So let's see what again our good friend Astro Guideline said, that irrespective of HER2 status, we can offer hyperfractionation. So the message is, even we know the left-sided breast, we need to take care of the hard dose. We are scared of cardiotoxicity after 3 to 4 cycle of Herceptin. We need to look at the echo, but still, John, comments.
You might come on to this in a moment, but how about TDM1, Kadcyla?
You have brought out one issue that I didn't do any homework. You can help. I have my homework on trastuzumab, but not TDM1.
Yeah.
So for TDM1, there's increased skin reaction. So if they're switching to TDM1 due to a non-path CR, then we pause their TDM1 until they finish radiotherapy. We don't give it concurrently.
Great. So it's a good information that in residual, when we move to TDM1, that they hold the radiation for the skin reaction. So you wait for the whole period.
That's the beauty of doing it in 5 fractions.
Oh, I see. Okay. Okay, John, thank you. So for trastuzumab, at least we can continue with this hyperfractionation. So Arup, when you are having this hyperfractionation, 3D conformal breast planning, what are the parameters that you look for? And you are evaluating a plan. It is a very, this orthodox type of question. Just how you accept your plan. What are the parameters you look into?
In case of
dose coverage,
dose coverage region, actually, I mostly do 3D CRT, and I have some patients who got forward IMRT. And in case of 3D CRT, That is mostly practiced in my institute, that my private institute, but in also in NICRH, we practiced 3D CRT in case of BCS, whole breast radiation. The parameters that I look for, first, my target volume, that is getting the adequate radiotherapy or not, which we know that mostly the IMRT can give a good conformity index and homogeneity index, and also the OARs, that is the heart dose, left antrodescending artery, the dose to the dose going to the lung. It is also a concern. And also sometime in the planning, whether we are using wedge or not, unwedged field or wedged field, whether we are doing a bolus or not, where is the hotspot. Hotspot is the volume of the hotspot, and with wedge or without wedge, what is the dose distribution, and how is the dose distribution. These are the parameters that I see. Also, I see the breast volume is also important thing to take decision regarding radiotherapy. What type of immobilization devices that we use, it will come in a question. And these are the parameters that I look for. And in case of 3D CRT, I always, mostly for the left-sided breast cancer, the heart dose and the lung dose, that we always look for.
Thank you, Arup. So what I understand that you are mostly doing 3D and in forward IMRT. Irfan, I'm sure in your institute you are using a institutional protocol. For a person like me, whenever any site we are doing hyperfractionation, I am quite concerned about all the things, because we have in imprint is the OAR dose of conventional fractionation. So we take granted that that is the dose, but when it is hyperfraction, the story changed. So what is the coverage that you accept for PTB, and what is the OAR constraint for lung and heart you do in your center?
I think one of the most overlooked studies to come out of the UK in the early 2000s was the comparison of 3D conformal radiotherapy with forward IMRT. So this was the trial which, in my opinion, actually changed the practice, at least in our institute. So as a rule, 3D conformal radiotherapy. So what happens with 3D conformal radiotherapy, I'm sorry, I'm going to go into a little bit of technical right now, but you will have, over the curvature of the whole breast, you will have a one very confluent 105% or more dose in some area of the field. Whether with forward planning, you can actually block off that region using the MLCs and reduce the volume of 105%. So that paper which was published out of the UK, which was one of the few overlooked trials like I was mentioning, actually characterized 105%, 107%, and the volume of the breast receiving these doses was about, cutoff was about 200 cc. So with 3D conformal, it's very difficult to restrict that. Our own institutional protocol is that for the dose receiving 105% or more has to be less than 100 cc. We've noted that this reduces reactions quite a bit. Irrespective of the planning, forward IMRT also gives you the flexibility of reducing the heart dose less than about 3 gray in our institution. It's very unusual cases where the heart mean dose increases more than 3 gray, which is actually the most robust parameter which we have till date to predict long-term cardiac toxicity. And what we sometimes forget, or what sometimes happens, is that women who do develop skin toxicity with whole breast radiation, especially after hyperfractionation. So most of these patients, if they're staying where we practice, in and around where we practice, do come back for 2 weeks to get their breast checked. What is their grade of reaction at that time? Because it's actually the 4th and 5th week with the hyperfractionated protocol that you start seeing the maximum skin toxicity. And to control that, I think 105% and 107% of the dose which you prescribe has to be controlled to as low as possible without compromising coverage. When it comes to coverage, our bare minimum acceptance is 95% of the dose is covering 95% of the volume. In exceptional circumstances, we reduce that to 95% to 90%, take it to the third step, which is 90% dose coverage And the criteria for rejection is that if the dose is covering 90% of the dose is covering less than 90%, we just outright reject. And we analyze the factors as to why we could not achieve it. Most of the times it is the breast separation, which is more than 22 centimeters. And in those situations, we then go ahead with inverse planning techniques like IMRT or VMAT.
What about the lung dose, Irfan?
So most of the literature on lung dose, as we all know, comes from the lung cancer patients, where the combined lung V20, 20% is sort of like sacrosanct, 20, 30%, 30, 20, 35%. Our institutional protocol is that for the ipsilateral lung that we are going to irradiate or is going to be in the treatment field, V20 has to be less than 15 to 10%, 10 to 15%.
Thanks, Irfan. John, are you there?
John left.
Okay. So Irfan, I was going to ask this question to John, that if there is a supraclav and an IM node,
yes, sir,
then the challenge comes with achieving the lung dose. Then how much you accept? We want to keep below 1620, V20, 20 or 16 gray, but when it is the 3 field with IM node, what is the maximum that you accept?
3 field with IM nodes, you mean to say you using a matched field for the internal memory?
Yeah. I mean, we are covering supraclav, we are giving axilla and also IM node. So whole breast, but the total RNI.
Total RNI.
This is sweating.
The physicist ought to sweat, because it's so the one option that we have is that we still go ahead with the 2 field matched axis center plan, one for the supraclav and the axilla, and try to take slightly deeper tangents than what we normally would. That would definitely increase the dose to the contralateral breast if it's intact, but that would still achieve comparable coverage. It's, in my opinion, and this is just my opinion, treating these internal memory with a separate field is just going to end up irradiating more hard. Well, if you have slightly deeper tangents, and with forward IMRT, you can just block off the regions successively with the portion of the heart which is coming into the convexity of the chest wall, you can achieve comparable doses. This patient would also ideally be suited for a deep inspiration breath hold technique if available.
Yeah. So I intentionally didn't bring up that breath hold technique, DIBH. That is a wonderful way to reduce the heart dose and also some lung dose, why not? And when we are having the IM node coming in the field, it is sometimes making the life challenging. So one question was always that start A, start B, there was no enough into disease, but now we are courageously treating all the node positive with hyperfractionation. Before we used to, personally, I used to do, when it's a node 50, when it is a less node or no node, go for hypo. But definitely. I think now we all are doing RNI with hyperfraction. Any comment on that, Irfan?
No, sir. I believe your practice is absolutely right, sir. There's really nothing that I can add. It takes some amount of time to wrap our heads around the fact that radiobiologically 42.5 in 16 is as good as 50 in 25. And how much more evidence do we need? That really is the question. It's not. We don't need any more for the 15 to 16 fraction regimen.
Thanks, Irfan. I've pulled out a nice paper by Berrywell and his group. They have, so John is here. John, I wanted to hear from him about this RNA issue. So I think John yet to join. Okay. So I was sharing this nice paper that was published in Red Journal by UPMC group in 2018. So as Irfan was saying, more or less the 95 is the coverage, but they can go up to 90, but below 90 they will not go. And as he mentioned that 105 is the cutoff and 110 is 0. So, and no tangent through the heart. So Arup, I have a question that when you are drawing your whole breast volume, is there any factor that can change the volume, that this, for this factor, I change my volume, or for any stage, anything, you take the same breast volume? Arup?
Actually, sir,
So let me give you the clue.
thank you.
With the stage, do you change your volume?
Yes, sir. I do change it. I do change it. Some of the factors you have already mentioned. One things that change, whether changing of staging can change the contouring or not. Actually, what I follow the Astro guideline and the RTOG guideline.
Okay.
As per the RTOG guideline, in case of the early stage disease, we can spare the chest wall. That is the breast only. We can practice major muscle and ribs that can be spared. This is one thing. And also Astro guideline, as per the Astro guideline, the early breast cancer, if it is T3, anything less than T4A, we can omit the chest wall radiation, breast only radiation. This is one part. And also in case of young patient, the recurrence, in case of contouring the supraclave, in case of young patient and TNBC patient, I do include the posterolateral aspect of the supraclavicular region. In case of supraclave, I used to include the posterior and the lateral part of the supraclave in case of young and TNBC patient. And in case of chest wall contouring, what I do in early stages, I just contour the whole breast. That is, I stay above the pectoralis major muscle. But in case of T4A or something like this, in those cases, I include the chest wall also. And some other factors also affect the volume, because in some cases we see that the drain tube scar or the scar mark is such a large scar that it cannot be encompassed in the tangential field. So in those cases, we are to increase the volume. And also, if it is a lateral or medially located or laterally located tumor, which is very close to the mid-axillary line or very close to the midline, in those cases, I take some extra few region towards the midline or in the left mid-axillary region. That is the volume expands according to the location of the tumor.
Thanks, Arup. Actually, you have gone to so many details. I was trying to just focus that this earlier stage, we don't need to take the chest wall. When it's advanced stage, that we need to include the chest wall. And as you said correctly, that for the laterality of the tumor, we select our nodal basin, and then the drawing of the volume is different. Somebody draws, somebody takes some beam direction and target the volume. And we crop the area from the skin to reduce the skin dose. So we move to our fourth question. Mahfouz, fourth question. What is the boost dose? Fourth question, Mahfouz. So 10 gray, 4 to 5 fraction, 14 to 16 gray, 7 to 8 fraction, 12.5 gray, 5 fraction. Okay, Mahfouz, stop it. So we have 57% participation, 16 or 22, 28. So majority, 9 out of 16 is in favor of 10 gray, 4 to 5 fraction. 3 out of 16 is 14 to 16 gray, 7 to 8 fraction. And 7 out of 16 is 12.5 gray in 5 fraction. Or Faria, what is your practice? Boost dose.
Usually we give 10 gray in 4 or 5 fraction, but if there is any other factors, risk factors like young age with margin positive and close margin, then we give 14 to 16 gray in 7 to 8 fraction.
So Faria, what is a negative margin for you? In invasive breast cancer, what is a negative margin for you? When you will say it's a negative margin to see the report?
Okay. Is there any line in the task margin, I mean, their incline is clear, there is no tumor, then it is clear margin. But we also think about closed margin. Okay, if there is tumor margin is more than or equal to 2 millimeters, then we call it widely negative margin. Then we can omit boost. But,
so can you omit the boost in some situation?
Yeah.
Are you giving boost to everybody, Faria?
No.
Who are the patient where you can omit the boost?
Okay, we can omit boost in case of older age, like more than 70 years old patient with low or intermediate grade tumor, and as I said earlier, that is widely negative margin, more than 2 millimeters. Then we can omit in case of invasive cancer.
So I am already exhausted my time, so I'm quickly going to the guideline. They are telling that recommended for patient who meets the following criteria: age less than 50 with any grade, 50 to 70 is high grade and or positive or a positive margin. Then we need to give. On the other hand, if the age is more than 70, receptor positive or low or intermediate grade with widely negative margin, we can omit it. But in DCIS, the scenario is a bit different. Here, the story of 2 millimeter is there. If it is less than 2 millimeter or positive, then we need to give it. But invasive margin on ink free is negative. So this is the quick recall. And now the last question, Mahfouz. Mahfouz, last question. So positive margin, what will be your preferred dose, total dose, 60 gray, 64 gray, 66 gray, or 70 gray? Considering 50 as, not hyperfractional, conventional. So I would have sent 10, 14, 16, and 20.
66 gray total, if there is margin positive.
So Faria, we are having the poll, then I will come back to you. So 44% have answered. So I think Mahfouz, you can stop it now. Okay. So 25% in favor of 10 gray, that is 60 gray in positive margin. Another 25% is in favor of 14 gray. 12%, 50% is in favor of 66 gray, and 8%, only one in favor of 20 gray. So 10, 14, 16, and 20 gray. So Faria, if positive margin, invasive cancer, how much you give?
I used to boost 16 gray in 8 fractions.
Sorry?
16 gray in 8 fractions, total 66 gray.
16 gray in 8 fraction.
Yeah.
Okay, Irfan, what is your protocol in your center for positive margin?
So I'm sorry, I don't understand why, if there's a positive margin on breast conservation, why, if you persistently positive margins, why would persist with a breast conservation? Why not then at that situation consider a mastectomy? Given the hypothetical situation, because I've never faced this situation before, my preference would be just picking from the literature 66 or 70 gray. So
Okay.
Total dose.
So there is some situation, Irfan, that in breast conservation, they don't do the frozen section, and sometimes we recommend that go for re-excision, as you said, or mastectomy. But some situation, re-excision is not possible. So in that situation, this positive margin story comes, and there is a group of believers. Somebody thinks that enough with the conventional, some things that we should give some more dose. So this is the gray zone, and fortunately, we have some comments from Astro again. I mean, there are quite conflicting data. In EORTC boost trial, they have shown that a higher dose has given lower recurrence, but another study didn't show any benefit of higher dose. So it is a gray zone. But what Astro is telling that the 14 to 16 gray in 7 to 8 fraction or 12.5 into 5 fraction could be used. So, I mean, as you said, the most important thing will be to go re-excision, because there is with no robust data in favor of giving a higher dose for giving a good control. I'm not sure John is there. Shuman, John could join or he could not join?
Not yet. I have not seen. Okay,
I
I had
sorry.
to move into my car. Sorry.
Okay, John, can you talk?
Yes.
So, John, I kept this last thing for you. Tell us something about this fast forward. We want to move really fast with this fast forward. Are you doing it for all node positive or only for the early stage?
So we've adopted it for patients who do not require lymph node irradiation. So providing you're not irradiating the axilla, SCF or IMC, we use it in those patients who fall into that category. So if they've got single lymph node, you know, we'll adopt it. So if they're having whole breast radiotherapy with or without a boost, then we'll do fast forward 26 in 5. And in regards to the boost, our standard boost used to be 12 in 4 with 40 in 15, but we've now moved down to 10 in 5 when doing 26 in 5. So we're not using 12 in 4 for 26 in 5 patients. So we feel it's a bit too hot.
So you are not still, so for us, we need to wait for the into data. So for patient not needing RNI, you are going for that. What technique you are using?
Precisely.
3D, forward IMRT or VMAT for 5 fraction, fast forward?
So we use, in fact, we use conventional planning. So we use 3D tangential fields, and then, you know, if it meets the criteria, the IPSI, lung dose, heart, etc. for fast forward, we'll accept it. So we tend to only use IMRT for patients where we're using IMC or nodal volumes axillary SCF. So if we can treat with just good old-fashioned tangentials, we will. It's interesting.
So are you in favor of 3D or forward IMRT?
So, so we will use 3D conformal for those patients where it's uncomplicated radiotherapy, where we can define the breast fields easily. And even then, when we're doing boost, we'll normally use mini tangent boost rather than anything too fancy.
One question,
We are
John.
moving though.
Yeah.
We're moving now though, so we're just starting to integrate dynamic MLCs for our whole breast radiotherapy to improve, as has been mentioned, you know, the hotspots and cardiac dose.
So if I am trying to do fast forward, do you have some caution
Yes.
for me that Kamal, be aware of these points? In bullet point, would you like to tell us that these are the area that we should be really cautious to start?
Yeah, I would say be cautious when it comes to left-sided breast radiotherapy, because as you can imagine, not all patients can achieve deep inspiration breath hold. And also sometimes, even if they make it through planning, when it comes to dose delivery, that 5.2 gray per fraction to the heart, you know, just bear that in mind. If you've got any concerns that they're not gonna be able to maintain it for all fractions, because it's quite a chunky dose, and we know that that mean heart dose is significant when it comes to late effects and cardiovascular disease.
John, regarding the boost, not for not for this extreme hyperfractionation,
Yeah.
are you in favor of electron or photon? Because nowadays I see our physicist colleagues are very fan of going for photon. So what is your comment on boost, electron or photon? Because we were trained with electron.
So I was trained with electron as well. I've got to say only one of my machines in the NHS still has electrons. Everything's moved to photons. So I maybe have done 1 or 2 electron boosts in the last year. Everything has moved to photon mini tangents now. I agree. There are patients with very small breasts where the boost is very, very superficial, that with some perspex and electrons it does offer, you know, I would say better dose conformity than perhaps mini photons.
Thanks. Irfan, what is your practice in your center? Boost for photon or electron you are doing?
So I just have a very interesting piece of information I would share with you. So before the COVID, we were doing predominantly with electrons, and as and when, because of COVID, so we couldn't do the manual planning on the machine with electrons anymore for COVID reasons. We shifted to photons, and what we actually found, this is something that we're still working on, is that, like Dr. John was saying, boosts in small breasts leads to more toxicity, skin toxicity. These patients tend to return back more with grade 3 skin reactions. Photon boosts in heavy breasts, more or less the same skin toxicity. The one area where we actually ended up discovering more grade 3 reactions was when patients had primaries in the outer half, more towards the axilla. And when we are boosting that area with photons, we tend to see a somewhat higher grade 3 toxicity just because of the attribute of the skin folds in that region. Given a choice between photon and electron, I would prefer electron any day. But with the current COVID situation, though now resolving, we've kept on with photons. So we still haven't done SIB. We haven't done simultaneous integrated boost yet. Because somehow, we're not very confident with that yet. So we're still doing sequential boosts with photons. We would love to switch back to electrons.
John, Irfan brought up a very interesting topics. I forgot to take. When is a photon, why not SIB, why sequential?
We are moving to integrated boosts, but I think, like Irfan says, our department is still getting to grips with essentially the planning behind it. So in other centers, so in the private sector where I work in Harley Street, it's been adopted. But in the NHS, where I'm working predominantly most of the time, it hasn't yet been rolled out for patients. We're still going through testing, essentially, Kamal. So we will get there, though.
Thanks, John. So what I understand, when we started radiotherapy in our life practice, we thought breast is the most easy treatment. And every day I'm growing and I'm realizing the most difficult treatment is the breast, and ever-changing area is the breast cancer. But most good thing is that this is one of the cancer where we have 20 years survival. We have a good feelings to seeing the patient after so many times. John, do you want to say something? You raised your hand.
Yeah, it wouldn't have affected this case, but I have started to do a bit of partial breast radiotherapy, and again, the protocol's about to become live in our NHS center. So again, which will add another chapter to this book, I think, for future teaching.
Okay, we'll be talking on that. Don't worry. We will keep you busy, John. So what I learned from the discussion, that breast cancer is a great area to learn radiotherapy, because there are everything you can do from 2D to IMRT everywhere. Irfan, want to say something?
Sorry to interrupt you, sir. There was just one question which you had asked prior to Dr. Arup, which was, what contouring would you like to use? And, so I think his answer was absolutely right. Leave the chest wall and all those things. Our group actually worked on this question, and we published a paper on this as well. Not to plug the paper, but just the conclusion, which is that for early stage breast cancers, you have a T1, T2. And if you follow the Astro guideline, you can achieve comparable results with forward IMRT versus inverse IMRT. When you have slightly advanced breast cancers where you need to include some part of the chest wall, which is actually what we compared using the RTOG one, you can end up using inverse IMRT, and that will probably have better dosimetric results. This is not a clinical study. This is just a dosimetric study comparing three types of planning techniques and 3 types of contouring techniques to see which one would result. And surprise, surprise, just the standard tangent delineation, which is, you place the tangents and you mark whatever region is that in the breast. That is also very acceptable as far as dosimetry is concerned. So not a plug for the paper, just the conclusions.
Thanks, Irfan. Personally, say I also don't contour. I put the beam and take the 50% iso dose and take out the lung. I'm not a work-savvy person, so I learned it from my colleagues from very well that they do like that. So we follow that. So what I was trying to say that in breast cancer, we are always looking at the dose, but we are forgetting about the OAR. When we move from conventional to hyperfractionation, the OAR is more important than the coverage because we are always looking at 95, 90, 100, 105 for the dose coverage, but we should be scared about the lung and heart dose because 1 gray in hyperfractionation is not real 1 gray. It is more than 1 gray because we are tuned of heart dose for conventional fractionation. And till today in the whole world, nobody knows what is the safest dose for heart. There are some gray zone for OAR, heart is one of that. And even in lung, because we are looking for the survival of 20, 25 years, if we really do some fibrosis, end of the day, the patient will live, but yeah, maybe on whole her life, she will curse me for creating some fibrosis. And just looking into these things, we can really look into it. And we should not forget the skin reaction. John was telling that, and it was a joke, but it is true, because sometimes it is really something very dangerous. So with these few words, Shumon is sending a caution that is 4:50 with 20 minutes more. My apology for being late. And we want to finish by thanking our academic partner, Roche. And next week, Dr. Mustafa Aziz Shumon will be our host. Topics will be confirmed to you later on. We have not yet decided. Dr. Zakirullah and John will be there. Farid, you are welcome to join. Irfan, you are also will be sending you the link. And hopefully we will have a wonderful session next week, same time. Before concluding, I will request our president to conclude the session. Hi, sir.
Thank you, Kamal. We had a very nice discussion today. Possibly we will continue this. We have had only radiotherapy of breast. Maybe continue this one as well. So thanks, Dr. Irfan. You have taken a very nice decision, very nice discussion. So thank you very much. Hopefully you have enjoyed this. Thanks to
Mahfouz, who's the winner of last week?
John and
Mahfouz, who are the winner of last week?
all the particulars.
So we have the 3 winners of last week, Dr. Suryana Sultana, Dr. Afroza Tania, and Mahmudul Hassan. So the prize will reach you, and this will encourage you to join in the next week poll to get a prize again. Unfortunately, we, the co-hosts, are not allowed to participate in the poll.
That is very unfair. I also want.
Okay, Irfan, thank you very much. Thanks to John, and I don't know Farid is there. John and Farid was, they were moving around and joining with us. So nice of them. And I see our senior colleague. Hi, John. So see you next week. So thanks to Dr. Parveen Banu, very senior colleagues for joining, and your joining is always encouraging us. So thanks to everybody. And with these few words, by thanking everyone and also to our academic partner, I want to finish today's session. Next week, same time, Sunday, meet you again to discuss on breast cancer, some other topics. Till then, stay safe. Goodbye. Allah Hafiz.
Bye. Allah Hafiz.
Bye-bye.